you who I maybe haven't met, I'm AnnaLena du Toit. I'm one of the dietitians that is working in the ICUs here. So for today's TAT, I thought we can maybe focus a little bit on the appetite of patients post-critical illness. And I think this is something that's come up quite a few times in the last month with our COVID patients, especially, who's been spending a lot of time in ICU, and when should we remove that tube, or how long should we leave the tube in, and how much benefit is there for the patients to be receiving more feeds. So the topic of the presentation, you can see, is the patient can eat. And often this is kind of my reaction when that question gets posed to you, the patient can eat. Can you really eat? Because there's so many facets that is associated with eating that will make the patient take enough orally or not be able to meet these requirements at all. It's a little bit more complex than just saying the patient is physically able to eat, and we will look at a bit of that. So the problem with oral intake and when we can remove the tube and appetite in the ICU is really that we've learned through the years that there's an acute phase, a chronic phase, and a kind of a recovery phase in the critical illness of the patients. And most nutrition studies are focused on the first 5 to 7 days of patients in ICU. And what we know is that during the first about 3 days in the acute phase, exogenous nutrition supply to patients are probably not that important. What we do know then is that after 3 days, and you're about 3 up to 7 days, it becomes very important to supply exogenous nutrition to the patient. But then what happens after that, during the later stage of the chronic phase and through the recovery phase, when exogenous nutrition supply is probably the most important to do, we don't really have a lot of data on what exactly is happening there. So if we look at the calories as the patient moves through the phases, we know that in the acute phase, patients probably don't need that much, and then the calories go up and up, as does the protein as we move towards the active or the rehab phases and the later phases or the later stage of the chronic phase. So this man that I'm showing you here is Ansel Keys, and you may or may not have heard of him. He was an American physiologist who studied the influence of diet on health. And he did the very famous Minnesota starvation experiment in 1944 to 1945. So what they did during that experiment was that they aimed to look at the physiological and psychological effect of severe and prolonged starvation on healthy volunteers, and then what it would take to effectively rehab these patients in terms of their dietary requirements. So the study population consisted of 37 conscientious objectors who were selected, and they were white males between the ages of 22 and 33 years. So relatively healthy and very young individuals that were participating in the study. So what they did was, at baseline, they fed patients 3,200 calories, which is quite a bit. It's at least 2 plates of the hospital food for each meal. And then when they tried to starve them for the 6 months, they basically fed him what we feed as a full diet to patients at 1,800 calories and 0.7 grams per kilogram protein. And then they actually lost weight so quickly that they had to give them a little bit more, because what they were aiming for is that patients should lose 25% of their weight by the end of the 6-month period. And then what they tried to do was to rehabilitate them and put this weight back on. So they divided them into 4 groups for 12 weeks, and they started giving them a little bit more calories. So they went up with 400, 800, 1,200 to 1,600 calories. Then after this phase, they just allowed the participants to eat as much as they wanted to. So what they found was that if you starve somebody for a prolonged period, there's an increase in depression, hysteria, and hypochondriasis. These people developed a preoccupation with food, both during the starvation and the rehabilitation phase. They showed signs of withdrawal and isolation. There was a decline in their concentration, comprehension, and judgment. They had a decrease in their metabolic rate. They developed edema, and they lost 25% of their body weight, which was the aim of the study to start off with. So during the rehabilitation phase, they found that when they started giving patients a little bit more, they didn't find any improvement in the weight in the patients in the lower calorie groups. And they concluded that patients needed about 4,000 calories, or participants needed about 4,000 calories a day to recover, which is, for a healthy human being, I think, a challenge to eat. But for a patient, that is something that I think we put almost out of their reach. And during the uncontrolled phase, where people could eat as much as they wanted to, they showed complete lack of self-control. They were binge eating. They ate until they vomited. They ate 8,000 to 10,000 calories a day, which is almost unimaginable. And this only normalized after about 5 months. They kind of went back to normal. It took them 8 months to regain all of their body weight. And then what they regained was mostly fat and not lean body mass. So if we pull this through to our patients in ICU, when they have kind of come through a period of starvation or deprivation while they were in the ICU, and now we move into a rehabilitation phase, this is the phase where we want patients to be eating about 40 calories a day and 2 grams of protein a day. But this is then the time when we get itchy to get that tube out. When the patient moves out of the ICU, then we want to send the patient to the ward with as little lines and tubes and things as possible. But the reality is that patients spend much longer in the ward than in the ICU usually. They receive less nutritional interventions in the ward, or at least maybe less intensive. And patients tend to do worse in the ward from a nutritional point of view, especially if they are left only to eat by themselves. So that then brings us back to the question of whether the patient can really eat. Is the patient able to eat? So if we just look at a few definitions, what is eating? So eating is the act of putting food into your mouth, chewing it and swallowing it, which, unless there is a contraindication or aspiration risk, most patients are able to do. Hunger is a feeling of discomfort or weakness, which is caused by a lack of food, coupled with a desire to eat. While appetite is a natural desire to satisfy a bodily need, especially for food. So if you have a patient that is hungry and that's got an appetite, that person would eat. If you have an appetite, you will eat without being hungry, which is often a problem in our more obese patients. But if you don't have an appetite, you probably will not be hungry and you would not want to eat. So if we just quickly look at the things that control appetite and satiety. So the first thing that plays a role is ghrelin, which is a 28 amino acid gut peptide hormone, which was discovered quite recently in 1999. It is synthesized in the gastric fundus, and it acts on the hypothalamus to stimulate hunger. If you starve patients for 24 hours, you see that there's a rise and fall in the ghrelin levels, which is associated with traditional mealtime. So to a degree, your ghrelin response could be conditioned. The next hormone that plays a role is PYY, which is secreted by the colon and the rectum, to a lesser extent also by the small intestine and the stomach, and that slows down GI motility and decreases appetite also by acting on the hypothalamus. The next thing that is secreted is leptin, which is secreted by adipose tissue, and that also then decreases appetite. But apart from hormones, there's also a whole lot of external factors that influence and regulate food intake. Things like cultural beliefs, psychological factors. When the patient is anxious or stressed, they might eat less. External stimuli like pain or noise. And then also internal stimuli, things like infection, inflammation, and alterations of the anatomy. So if we want to say that a patient can eat, we first need to maybe look at a few things, and we'll go through that one by one. So we spoke about the appetite hormones. Now, does appetite hormones in intensive care patients change? So this is a study that was published in 2006, where they took 16 ICU patients and they compared them to 36 healthy volunteers, and they looked at their ghrelin and PYY levels. So on the screen there, you can see the controls is the blue line at the top, whereas the patients are the little red dots. So you can see that, and then at the bottom one, PYY is low, the blue line at the bottom, and then the patients are at the top a little bit higher. So you'll remember from the previous slides that ghrelin stimulate your appetite, whereas PYY suppresses it. And in this case, the patients and the controls are exactly the other way around. So they have less ghrelin, they have more PYY, so they have less stimulation, more suppression of their hunger. And you can see that it's only at about 21 days that starts changing, and there's a decrease in PYY and an increase in the ghrelin. So there is a positive association between PYY and Apache 2 scores. So the higher the Apache 2 scores, the more you'll have suppression of the appetite, and a negative correlation of ghrelin. So the higher the Apache 2 scores, the less appetite stimulation and the less appetite scores. So this then translates into less sensation of hunger, more nausea, higher satiety, and significantly lower intake for our ICU patients. This is another study that was published in 2018, which looked at appetite scores post-ICU discharge for 3 months in 240 patients. What you can see on the graph here, the red line in the middle is an appetite score of about 5 out of 10. The blocks on the left-hand side of your screen are patients that stayed in hospital for less than 5 weeks after they were discharged from ICU, whereas the circles at the bottom are patients who had a long hospital length of stay, more than 5 weeks post-ICU discharge. You can see that for the entire 3 months that these patients were followed up, the patients who stayed in hospital after ICU discharge constantly had an appetite score of less than 5 out of 10, and it was only at 3 months that it started crossing that line and going over, whereas your patients that were discharged earlier had a far greater recovery of their appetite. They also found that the higher the CRP post-ICU discharge, the poorer the appetite score in these patients were. So then in terms of evaluating the oral intake, so we know now that appetite in patients post-ICU is suppressed, and it is based to an extent on hormonal derangements. But then can we say that patients post-ICU really eat less because of this appetite suppression? So this was a convenient sample of 79 adult ICU patients who were extubated and had no contraindication to oral diet, and they were followed up for a month after ICU discharge. So in the study, they said, okay, if patients can eat more than 2/3 of all of the meals served to them, then they are eating enough. It's not 2/3 of the hospital soup, it's 2/3 of the actual meal. And what they found was only 60% of patients weren't even able to complete 1/3 of the meals that were served to them, whereas only 3% of patients had what they regarded then as an adequate intake of more than 2/3 of the meal. So what if we give them oral supplements? Unfortunately, not all of the patients who had an inadequate intake got even offered supplements. So only 32% of patients with an inadequate intake got offered oral supplements in this study. Then this is another convenient sample of 50 adult ICU patients who were ventilated for at least 24 hours and then advanced onto oral intake after ICU, after extubation. They didn't receive any supplemental EN or PN, and they were followed up for a week after the extubation. So they worked out their requirements very similarly to what we would do, and they said, okay, if you can eat 75% of your requirements, then you are taking enough orally. In the graph here, you can see the 7-day intake. The red line at the top is indicating the adequacy at 75%. And you can see that the mean intake for this entire week was less than 55% of the prescribed protein and energy requirements. So then what can you do about it? Surely you can get the dietitian to go to the ward and speak to the patient, and as we often hear, encourage the patient to eat. Unfortunately, it makes absolutely no difference. 60% of these patients were assessed and monitored by the dietitian, and there was no difference in energy intake. And when they were offered snacks and supplements, all patients were offered the snacks and supplements, but 35% of patients said, no, thank you, I don't want it. And of the ones who took it, there was no difference in intake between the groups. So then, if we move on, we see, okay, so patients have derangements of gut hormones and of appetite hormones, and yes, they don't eat enough if post-ICU, but maybe it's because they still have the tube in, that they're not able to eat enough. And these are are things that we often hear. We've taken the tube out because we're going to encourage the patient to eat and drink. We're going to allow the appetite to grow because it's being suppressed by the artificial feeding. We must just push for full diet now the tube is out. But if we look at the effect of artificial feeding on appetite, the reality is that parenteral and enteral nutrition are unphysiological methods of feeding. We infuse liquids over a prolonged period of time. It's often done at night when most people don't really eat. We bypass part or most of the GI tract, so it's really not equivalent to somebody eating. And this all leads to a disturbance in appetite sensation because the cephalic phase of eating is being bypassed. The cephalic phase of eating is an autonomic and endocrine reflex, which is triggered by the sensory contact of food, the smell, the taste, the seeing the food, the sound of the food, and the stimulation of the receptors through chewing and swallowing. So if you don't have that oropharyngeal stimulation of eating, you don't experience the decrease in hunger and the increase in satiety. And this then plays a role in satiety and appetite regulation. So if we look at patients receiving artificial feeding, this is a small study published in 2016 where they had 20 participants receiving oral and enteral nutrition and 25 participants on oral intake only. And what they found was that there was no statistically significant difference between the amount that these people took voluntarily. So there was no significant difference in voluntary intake, no significant difference in appetite score. The most people said, I don't eat a lot because I don't have an appetite. I didn't finish my meal because I don't have an appetite. It had nothing to do with the enteral nutrition that was administered to these patients. So if we look at patients on exclusive enteral feeding, patients who maybe can't take orally because of the aspiration risk, patients post-CVA, it doesn't satisfy hunger. 50% of patients who are on exclusive home enteral nutrition still reports that they are hungry, whereas 33% of those patients are distressed by their level of hunger. Does it replace the calories that the patient would have eaten, or does it add to oral intake? So majority of what we supply through the enteral route, about 80%, is additional to what the patient would have eaten if he did not have that tube. Can Ian stimulate the appetite and intake? And yes, that is true, especially in our malnourished patients, where if we feed them a little bit and we get their nutritional state a little bit better, they tend to be stronger and develop more of an appetite and want to eat a bit more. So if we look at PN, does PN suppress appetite and satisfy hunger? If you look at acutely ill patients on exclusive PN, 89% of them still says, I'm hungry. Long-term PN patients who are able to eat a little bit orally report that they experience a little bit less hunger. Whereas your home PN patients, about 75% of them experience hunger, report that they experience hunger. And those who didn't report that they experienced hunger are the ones with increased acute phase protein levels, the ones in an inflammatory state where it's more associated with the inflammation that the appetite is suppressed than with the administration of the PN. So does PN replace or add to oral intake? Unfortunately, studies are a bit confounded and influenced by the disease and the drug therapy and the therapeutic diets that these patients are on, because often their diets are very restrictive, so that decreases the oral intake. PN plus oral intake does increase the total energy somewhat, but PN does replace some of the energy supplied from food, depending on the amount of PN that you give, the composition of that PN, especially on whether it's fat containing or not, and over how long period you administer it. Okay, so does oral nutrition supplements influence appetite? So this one looked at 24 healthy, slightly underweight volunteers, and they did a single-blinded crossover study with them. So what they did was, pre-breakfast, they gave them a high-energy oral nutrition supplement to drink. Then they served them a buffet breakfast an hour later and lunch 4 hours later. And what they found was that the group that had the shake said prior to breakfast they feel a bit full, and they had less hunger and had more satiety and less desire to eat. but by lunchtime, that had disappeared. So although the intake at breakfast was significantly lower than the placebo group, they ate about the equivalent of 14% of the energy provided by the supplement less. And by lunchtime, there was no difference in their intake. So oral nutritional supplements results in an improvement of calorie intake equivalent to about 25% of the energy that is supplied by the supplement. This is another study which is actually a systematic review of 36 randomized controlled trials with quite a high number of patients, almost 4,000 patients included, but quite a high mean age of 74 years, which is maybe not quite what we see in our patient populations. But what they provided them with a daily supplement that provided between 200 to 900 calories per day. And this resulted in an improvement of about 300 calories and 22 grams of protein per day, which I think for some patients can just make the difference between being able to gain weight or effectively take part in their rehabilitation, in their physio, mobilizing, sitting in the chair and rebuilding some of that muscle mass. And the oral supplements that were provided didn't make any difference to appetite, and it didn't make any difference to the voluntary intake of the patient from the diet. So what they got from the supplement was really an extra. So if we take all of those things into consideration, then it really is about more than appetite. So it's related to reduced appetite, nausea, vomiting, taste changes, breathlessness, which we saw now during COVID a lot in our patients who were really short of breath, the ones on high flow nasal oxygen, where they're really too short of breath to eat. Diarrhea influences that patients experience, early satiety, there's pain, weakness, and fatigue that also influences it. But then outside of the patient, there's also a lot of things that plays a role in terms of the service delivery and the organization that the patient is in. So a lot of us would have seen the hospital meals. It's often not quite in the taste of the patient. It's not what they are familiar with. It's not what I normally eat at home. I might have gone for a CT scan and missed the meal. When I get back, my food isn't there. It's not the meal times where I normally eat. I mean, supper gets served at 4:30 or 5, and patients are not receiving things like oral nutrition supplements. It's maybe not delivered, goes missing in the ward. And then there's also other psychosocial involvement, things like altered body image, depression, and delirium that plays a role. So this paper was published in 2016, where they actually did structured interviews with nursing staff, doctors, dietitians, and then patients who are involved in the nutrition support of patients. And these are some of the things that patients say or said in these interviews. So often patients describe taste changes. They say the food is very bland, or it's too salty, it tastes metallic-y. Food that I previously enjoyed, I don't want anymore. I ask my family to bring me my favorite dish, and when it arrives, it's not the way I remember it. I take a few bites and I'm full. I can't eat because I'm in constant pain. My sleeping patterns interfere with my meal times. Eating is no longer a pleasure. It becomes a chore. It's something that you need to do. And patients don't always have the insight and ability to see that despite the fact that I don't have an appetite, I need to eat. I'm not hungry, I'm not eating. And often you ask patients, how much did you eat? And my favorite response is, I ate enough. Now, your enough and my calculated enough might not be the same thing, but some patients think, I ate until I wasn't hungry anymore. I didn't eat because I wasn't hungry. So how important is it really for me to eat? And some struggle to have that insight. They deal with many changes to their bodies and their identities. They have a reduction in muscle strength, in their physical appearance. Suddenly, a guy that was able to go to the gym and do his own daily stuff is weakened and feels fatigued. And that leads to anxiety, stress, fear, frustration, and concern in these patients, which also then impacts on their appetite. Often we put patients in isolation units because of hospital-acquired infections, and we put them in a unit behind a closed door, and their food gets put in there and the door gets closed again, and it becomes a very isolated environment for them to eat in. And often patients eat less because eating is actually a very social thing for most people. So that isolation might also make them then eat less. Meal times are often different to what the patient is used to and not so spaced out during the day. So patients may say, well, I was able to eat lunch, but then when I was able to eat breakfast, but when lunch came, it was only 3 hours later and I wasn't hungry, and then I ate supper again, or the supper is too early, that's not the time I traditionally eat, and I don't eat supper at that time. So what can we do about this lack of appetite and poor oral intake that we see in these patients? So this is a study of 32 ICU patients who were assessed for 28 days or until they were discharged from ICU. And they received oral nutrition alone with oral nutritional supplement, or oral nutrition with enteral nutrition as an addition. So the outcome of the study showed that if you leave patients to just eat, patients will typically eat about 37% of their required energy and about 48% of their required protein, which is quite poor. If you couple that with the oral nutrition supplement, so the SIP feeds that we would usually give to patients, it improves quite significantly to about 73% of energy and 68% of protein. But if you give patients a little bit of enteral feed and you allow them to eat on top of that, and we now know that the enteral nutrition will not suppress the voluntary intake of the patient, you can bump that energy up to about 104% to 99% of protein. And I think if we are talking about long stay patients and we are talking about patients who are in the recovery phase and that we are putting a lot of effort and resources into to get them rehabilitated and back to a functional baseline, then that is where we need to sit. We need to be providing those patients with enough energy and protein to ensure that recovery. So when we decide whether patients are able, or when we say the patient can eat, we need to make sure that the patient has got the neurological and physical ability to eat. Patients need to be evaluated by speech to see that there are not aspiration risks. We need to identify the patients who need assistance with eating, or the ones that need special diets, patients who might have a chewing problem. Often we find patients in the ward who say, no, I haven't eaten because I don't have my dentures. And those are things that needs to be picked up and sorted out. We need to monitor the oral intake of patients, particularly those who are at risk. And then we need to consider delaying the removal of nasogastric tubes or reinserting it if necessary. Nocturnal enteral feeds is always an option, so we can feed the patient a little bit of extra overnight while they're sleeping and leave them to eat during the day. And the dietitian should be left to assess the readiness for NGT removal before that gets taken out. For the use of oral nutrition supplements, there needs to be a clear process for when and how oral nutritional supplements should be administered, and the patient should be counseled, because often patients don't drink the supplements because they think it's a little nice extra thing that is being given to them to drink or not to drink, depending on how they feel. And often when patients understand better what it is about, they are more likely to drink the supplements or ask for the supplements. We maybe need to look at serving smaller portions more regularly to patients, be more accommodating in terms of meal times, look at a more dining room style eating versus bedside eating in wards where that is possible, and then make provision for food preferences, cultural and religion within our menus, which is something that is often very restricted within the organization, just because they are already making so many meals and variety becomes a bit of a problem. If not necessary, we need to avoid restrictive and special diets because that just makes patients eat so much less. We need to involve the patient and the family in the nutrition decision and care. We need to actually counsel the patient, counsel the family, speak to them and ask them, do you want to take the tube out? And often I've seen patients in the ward where there's so much pressure on them from the family, from the doctor, from the dietitian to eat and eat and eat. And the patient says, I can't. And the moment you put an NG tube into that patient and you take that stress away from them, there's so much more peace and quiet around meal times, and they can then slowly build that confidence to eat. We need to ensure that there's adequate pain management, adequate management of nausea, and adequate management of constipation if it is relevant. In conclusion, what we know is post-critical illness appetite is decreased. It's multifactorial. And it stays like that for a long period. Oral intake is not enough. Artificial nutrition does not suppress appetite. Oral nutrition can improve the nutritional efficacy, and oral intake is about much more than just appetite. So if there's hunger and there's appetite, there's an ability to eat and there's food availability, somebody or a patient will eat. If a patient doesn't have appetite, he's weak, he's isolated, he's got an inflammatory process going, and is depressed, he will not eat. Doesn't matter what it is that we have on the menu, how delicious it looks, that patient simply can't eat and will not eat. And then we need to consider helping those patients. With that, I thank you.